Good morning, and reporting live from IDTV channel 679-2578. And I'm Katie McCrane, here to bring you some breaking news from Damal Walker.
Thank you, Katie. Thanks for having me on this show today. I was really surprised. I didn't expect this coming from a little pharmacy student like myself. But I'm here today as well to give you guys some updates on something interesting. So hear me out. Today's topic is on penicillins.
Whoa.
Yeah, not many people know about it, but penicillins, they actually revolutionized the world by Alexander Fleming in 1928. And after he returned from a month-long vacation, he noticed some mold was growing on like a contaminated specimen that he was working on. Then he went to throw it out, and then he actually noticed that the mold was actually killing the bacteria.
No.
Yeah, so then he did some further investigation, and he found out that the mold was called penicillium, and it released a substance called penicillin.
Whoa.
Yeah, so since the discovery, it has led to many once incurable deaths. They've now been easily treated. And today, penicillins, they're categorized based on groups. But wait, all penicillin beta-lactams, they have this mechanism of action where they inhibit the cell wall synthesis, which ultimately leads to the killing of the bacteria. But we have to be careful though, because penicillins are known to have the highest rate of allergic reactions in patients.
That's not good.
No. And in fact, the CDC reports that the allergic reaction rate to penicillins is about 10% in the US.
Whoa.
But they did, with further investigation, they report that less than 1% of patients actually have a true allergy.
That's not a lot.
No, so patients, they're not really sure about it, but they report having the reaction to it. So we have to be careful of that.
Sounds like it.
Oh yeah. So let me get to the penicillins. There are 4 categories. You have the natural penicillins, the anti-staphylococcal penicillins, the aminopenicillins, and the anti-pseudomonal penicillins.
That's a lot.
So let's explain each category further. So first we have the natural penicillins. So you have Pen-G, the IV formulation, you have Pen-VK, the oral formulation, and then you have benzathine penicillin, which has 2 formulations, the IM formulation, intramuscular, and the procaine version. So the differences between the two is that there's the treatment of syphilis. So the IM formulation is longer acting and it can be used to treat syphilis. However, the other procaine form is a controlled release and can't be used to treat syphilis. So yeah, doctors should be wary of that, and other students as well.
I'll definitely make sure to use that in my clinical practice.
Oh yeah, Katie, thank you. And then furthermore, the coverage, they cover gram-positive such as beta hemolytic strep, gram-negative such as Neisseria meningitis. They also have anaerobic coverage, and also covers, as I said before, syphilis. Secondly, we have the anti-staphylococcal penicillins. And these agents are oxacillin, nephicillin, methicillin, which are all IV formulations. And then you have cloxacillin and dicloxacillin, which are the oral versions. And these penicillins, their main spectrum of activity is against anti-staphylococcal infections.
That makes sense.
Oh yeah, given the name, which includes coverage against MSSA and also beta hemolytic strep. But they have no gram-negative or no atypical coverage.
That's good to know.
Definitely. So the third category is known as the aminopenicillins. And these include amoxicillin, which is the oral version, and ampicillin, which is the IV formulation. And by themselves, these agents have a narrow spectrum. However, when they're combined with a beta-lactamase inhibitor, they have a much wider range of action.
Like what?
Well, let's get to it, Katie. Amoxicillin is combined with clavulanic acid, and ampicillin is combined with sulbactam to give the coverage. And this increased coverage includes MSSA, beta hemolytic strep, enterococcus, listeria, MRSA, and they also have gram-negative coverage such as H. flu, E. coli, Proteus, and B. frag. Lastly, we have the anti-pseudomonal penicillin category. Here we have our main agent in the form of piperacillin. It is combined with a beta-lactamase inhibitor in the form of tazobactam. And when combined, the coverage is very broad. And this includes alpha and beta hemolytic strep, MSSA, and a wide range of gram-negatives such as spacem, all enterobacteriaceae, and B-frag again.
We don't like that B-frag.
We don't. So we have to know which ones cover it. This is all very interesting, but we must keep in mind about penicillins, Katie.
This is really interesting.
Oh, yeah.
I'm pretty sure I've taken some of these before.
You have?
Good to know now.
Yeah, definitely. We all have to know about this. And in fact, they are very effective if used appropriately. And we must ensure that we utilize them as our first-line antibiotics if clinically appropriate. And thanks for having me today, Katie. Are there any questions you need to ask?
No, Damal, I think you covered it all.
Yeah? All right, thank you. Okay, so for all the students out there, we just want you to know that penicillins, might be underutilized, but they have a definite place in clinical therapy today. Penicillins, their coverage can be very broad or very narrow, depending how we use it and based on the class. So it's important that we decide which penicillin to use, which class, how to use them, the dosing interval, which varies. The dosing is very broad to say it because it's going by the class, but the dosing is very important to avoid like resistance and stuff like that. So we have to be very wary of everything like that. So all in all, penicillins are great. And today, thank you for having me again on IDTV, and thank you for my host, Katie McCrink.
Great to have you today, Damal.
Thank you.